Well, good morning. I hope everyone's having a good time here at MD Expo. So what we'll cover today is a little fluoroscopy. It's not going to go really in depth into it like the guy next door probably would, but we'll cover the highlights. So if you want to learn more or have an interest in it, we'll certainly hit some of those. And then I'm Brian Wilson. So the scope of the presentation will introduce, apologize for the microphone, it's a little enthusiastic this morning. We'll introduce the basics of fluoroscopy, different types of fluoroscopy units that you might encounter, how images are produced on that, and then some of the advancements over the years on the technology of fluoroscopy. So what exactly is fluoroscopy? So when I teach some of my other classes, basically what I try and describe fluoroscopy versus conventional X-ray is like your phone. So on your camera, you have your photo option, and then you have your video option. Well, conventional X-ray would be like your photo option, and then fluoroscopy would be your video. One thing that is the same between them is that they make X-rays the same way. So if you have a fluoro system versus a conventional X-ray system, the X-ray production, the generator, all of that are identical. It's what they do with the X-ray and how they record it afterwards that sets the two apart. One of the things that fluoro can do, just like conventional X-ray, is it can do what they call a spot shot. And what this will do is, if you've worked with any OR like C-arms, you can just take a standard straight X-ray. You don't have to, it doesn't have any movement, doesn't have anything fancy to it. You just take a picture and it will look maybe not quite to the resolution of a conventional X-ray, but it still gives you that single frame image. Another thing that fluoroscopy can do is what they call fluoro runs. So basically what a fluoro run is you get actual movement in the image. So when you press down on the exposure button till the time you release the exposure button, you're going to be making X-ray and be making images. The only drawback to a fluoro run over the next thing we'll cover on a cine run is that the fluoro ends at the last image. So what that means is you don't get any more images once you let off that exposure button, and you only get the last image. So if you want to like record it, you have to then do a photo save or a kind of a end around spot run. Now the next level of fluoro would be the cine run, and basically cine is an old-timey term on the old cinematic cameras that they used in Hollywood. So the older systems used actual Hollywood cameras and put it on the output of whatever was recording the X-rays, and then you could actually run film. So then you could have a full recorded run of the image that you were, whatever part of the body that you were imaging. Then of course with advances in technology, then that became digital. So then it's stored in a digital recording device, and then whoever the clinician is then can go back and look at the actual runs like you would real time, like TV. So we'll get a little farther in here. Okay. This remote has got the like tiniest buttons on it for my fat fingers, so I apologize if we jump around a bit. Okay, so what are some of the different systems that you might run into in the hospital that uses fluoroscopy? Probably most people would be familiar with the portable C-arms that you see in the OR. They're fairly abundant, and if you work around the OR in those areas, you'll run into the C-arms all over. Another area that you'll run into fluoroscopy is urology, and that's kind of a more specific application of it. As a matter of fact, a lot of places probably don't even have a specific urology room anymore, but you might still run across those. Another system that you'll probably see not in great abundance is the rad and fluoro rooms, RNF, and these rooms you'll find mostly in radiology. You may occasionally find them in a specials room or even like maybe the GI lab. The next one would be your vascular systems. That includes your cath labs and IR. And then again, another kind of specialty version of those systems are the biplane systems. And again, you'll find those in interventional radiology and in the cath lab. Okay, so here's kind of an introduction for a lot of people to the world of fluoro. So you'll see these guys like hanging out all over the OR. You might see them in some of the special procedure rooms up in radiology, but 9 times out of 10, you'll be seeing them up in the OR. Just kind of a little breakdown of it. So right here's where your X-ray tube is. Most of your fluoro systems generally are posterior to anterior, so it will go from the patient's back and then come out, and then in this case go through the image intensifier where there's a camera up here, and then the camera will record the image and then send it over here. And then, like I said, how you deal with the image, then you can control from here. So like this guy here's like a spot shot. So take well, I was doing a PM on it, so I was taking various pictures of different phantoms and other things I could throw at the beam. And then you can also view the moving images on this screen. And then on here, then you can click the photo button, and then it will store that last image on the this screen, and then you can save it as part of your file. And then the more advanced setting is the cine image. So it'll actually do a complete series of imaging. So say you do a run of 30 photos, it'll get stitched into one continuous view so that you can watch it over a timeline and record the movements. So like in the OR, say if they're, I don't know, doing work on the elbow, and they want to make sure that the elbow has its full range of motion, then they can do a cine run, and then they can start the elbow or the arm at this position and then move it all the way to its complete end, and then have the full thing so that the surgeon can go back and say, oh, we got a hang up here, or everything looks good, we got a full range of motion, so we're done and can move on. So there's a number of different modes this can be used in. One thing to keep in mind, one of the things that makes a fluoro system different from a conventional X-ray system is the collimator. So the collimator in this case would be like right under here. Some of the collimators can be really simple. So if you notice like a normal X-ray system, you've got the 4 blades that come in that set your field of view. And then, if you're taking a picture of your wrist, then it'll just have your wrist in the image. On the fluoro systems, a lot of them have 2 collimators. So you'll have a collimator for your field of view so you can focus on what you're looking at. And then you'll also have a spiral collimator that will control your dose. So as the run goes through, if you say are going through a range of motion, you can change your dose based on your density. So if you're doing your wrist to your elbow, you can start off at a small dose, and then as you go up your arm and to your elbow, then the dose can increase so that it's able to do the range of imaging that you want. Otherwise, your elbow would be kind of blurry and would need some more dose for it. Where with like cine or fluoro, then it's able to adjust to the density of the area that it's looking at. again, I mentioned earlier, urology systems are kind of a dying dinosaur. I mean, you'll still find them out there. They're a very simple system. Unlike most fluoro systems, this is actually anterior to posterior, so the x-rays come from the top, like a traditional x-ray system, and then they go to the through here to whatever the camera device is. So it'll actually be coming through the front of the patient unless they're prone. And then you'll be able to record your images on your detector or whatever the recording device is. Most of them have now been replaced or getting replaced by using a traditional OR C-arm, and then you'll have a radiolucent table, urology table, so that they'll be able to see the patient's anatomy through the table, and then they can use the room for other things besides just urology. So this is your standard rad and fluoro room. It's an older Philips system. Some of the unique features on it are the X-ray tubes mounted under the table. So again, it's PA, so it's posterior to anterior direction where the X-rays go. This room also has a traditional X-ray system on it, but it uses the same generator, and it'll have its own recording devices for the different modes. But basically everything else is common. With the RNF room, what they can do is they can take this table and along with this fluoro tower, and they can tilt it. So they can have the I guess head side standing straight up, and then the foot side will be down to the ground. So, and then this fluoro tower then can go back and forth, and we'll cover some of the stuff they do with that. So it's I guess kind of what we call the recreational system. It actually can tilt and move and do other stuff than just your traditional imaging. This also has spot shot, fluoro and cine modes on it, so it can record a single shot, it can record a moving shot, and then it can also record a moving shot. Typically these rooms only go up to about 12 frames per second when they're using it for cine. Next one, kind of more specialized, is your vascular systems. This can include cath lab, interventional radiology, some neuro rooms. There's really no distinction between them. They're basically the same system. It's just what type of procedures they use for them, and then what kind of mode that they use. There's several different modes that you can configure these to run in. Interesting story behind this one particular room. It was reported to CMS and the state health department that in this room during a blizzard because they couldn't get a OBGYN to come deliver the baby. Come to find out in the investigation that this story was completely untrue. A cardiologist did help evaluate the new mom because he was one of the few doctors available in the ER, but they were able to, the police were able to get a competent OBGYN and L&D staff in there, and they were delivered in the L&D, and mom and baby were fine. So where the story came up that they were delivered in this room, no one knows, but they had to investigate it anyway. So kind of, I don't know, one of those things, reality's weirder than fiction. So the next kind of specialty, like you might see in like for neurology, where they would see someone that had like a stroke or an aneurysm, is a biplane room. And so what makes a biplane room different is you have your P to A lateral or regular view, and then back behind here you can see the other arm that comes along and will do your lateral shot or like your horizontal views. Like I said, this is more for specialty kind of stuff. They also like to use them for pediatric cath labs because it gives the patient less radiation, which is ideal for dealing with children. Some of the early history of cath labs. So this picture's from the 1950s, though it has a lot of similarities to kind of what you might see. So basically, fluoroscopy probably came out sometime in the 40s, but you had to have a special scope and you had to have goggles to be able to see the image. This is kind of the first example where they actually had real live video that they would use. So here's your image intensifier right here. And then up here you have your camera that's recording the video, and then it would be displayed on this screen here so that the radiologist or cardiologist could then continue on with their procedure. I kind of have to laugh that asking a cardiologist or a radiologist to use this as their reference screen would be a little challenging in this day and age, considering how big the screens are now. But so yeah, so they were, I guess, well over 60 years ago using the technology. It was kind of primitive, but worked for the purpose that they needed. And then here's a similar system from the 1960s. This device here is the image intensifier, so the X-ray would come up through the table, through the patient, hit the image intensifier, and then somewhere up here, which you can't really see, there's a camera that records the output of the image intensifier and then puts an image where the clinician can then view it in real time. So here's kind of an earlier system. So right here you have the image intensifier. So the patient table would be down here, and then the X-ray tube would be down here. X-rays would come through the table, through the patient, come through the image intensifier, and then come out the output. And in this case, it had two outputs. So you had your video camera over here that would record the images live, but it wouldn't save them. So whatever, when the doc took their foot off the pedal, they'd have the very last image up on the screen. Now here's where I was talking about the Hollywood movie cameras, that they would then connect to the other side. You would put film in it, and then you would film it like if you were filming a motion picture, except it would be black and white X-ray. And then from here, you would take the film out, and there was a special film developer just for cinematic film. The film would then be developed and then viewed on an external viewer. They were using basically this technology up until the late 80s, early 90s. So it's not as distant as you might think based on the age of the technology. So here's another view. This is from the 1970s. So again, due to the video technology of the time, we still have these tiny little CRT screens that the doc's viewing this on. Back here in the corner, you can see the C-arm, so that it's more in line with what we currently have. Up here is the cine camera that has the film in it, so it's a little more compact. And then on the other side of there would be the video camera. Same setup. You can only see the last image of the run after you take your foot off the pedal. This would then record the cinematic film. Then it's not in the picture. They would have a special film developer that you would put the film in, and then this rather lovely piece of equipment here is where you'd view it on. Now, again, you would think this technology, I mean, this was probably late 1970s. I actually had to still work on these. Some of the older cardiologists wanted to see their old films from 20 years before. Well, no one knew how to run this thing, so I would have to spool it up. There'd be two big spools, and I'd have to spool up the film for it. And then the doc had a foot pedal that he would stomp on, and then it would run it through, and then he could back it up and run it through. And then when he wanted to look at the next film, then I'd have to come in, change it for him, spool it up, and then he could look at his thing. And that would have been early to mid 2000s when I was still doing that. Now, I don't think any cardiologist is still doing his job that would have still used that stuff. But back then, they were still insisting to see their old cine films from back in the 80s and 90s. So how's the images made? So there's basically three different ways that they made primarily the video image, but you could also do the cine off of them. So the first technology was the pickup tube. And basically these were old TV cameras from like the 50s, late 50s is when they first came out. And this would be what they would have actually filmed TV shows with, or your news coverage with, was these pickup tubes. They were 100% analog, but I'll actually say probably up until the past maybe 10 years ago, the images from the pickup tubes are actually better than the digital equivalent. The newer systems have picked up their resolution quite a bit, so the pickup tubes are kind of, not the thing anymore. But they actually did make some really good images for their technology. About the 1980s, probably 90s, is when they came out with the charge coupled device. And so the charge coupled device was a solid state camera. They still use CCDs. You'll still see them on some of the older like C-arms in the OR. And some unscrupulous mammography companies will call their digital detectors, and they're actually a CCD camera. So they'll advertise that you're getting a digital image, and you're, kind of for debate whether you can really call a CCD image a digital image. They are solid state, so there is no analog to them, but they're not totally digital either. And then the next one is your digital detector, and it's what they currently use. So the digital detector takes X-ray, converts it to light, and then converts it to a digital image, and then sends it over to the image processor. So it's 110% digital. The image is available instantaneously. So as they're going through the case and say they're in the heart, what they see on the screen is actually what's going on in the patient. So here's a pickup tube. Last pickup tube system I worked on was a few years ago. The radiologist was incessantly complaining about how this old crap, why would they even have to use this stuff, and on and on. And I said, Doc, I understand these things are old. They were made back in the last century, and they were quite elderly and had their, maintenance issues, but they really made a nice image compared to the early digital. It would be like having a really nice video image versus, say, like what you could do with an iPhone 3 or an iPhone 4. I mean, the digital technology just hadn't evolved yet. And they, like I said, complained, and they finally got their wishes. They got rid of this old-timey system, and then they got the latest and greatest digital. And they came up to me, and I was pretty surprised, and they said, yeah, you're right, this image is crap. I want my old system back. And I'm like, yeah, sorry, it's in the landfill by now. So there was some valid or validity to these older technologies. The only drawback to the pickup tubes were that they took a while to warm up. So if you had to run someone in for like a quick exam, the image quality was really bad until they got the temperature. And some of the earlier ones had a digital lag, or like a lag to the image. So as you stepped on the pedal, you weren't seeing it in real time. You were seeing an image that was, I don't know, a few seconds older than what you were actually doing. but that improved over the time that they were used. And here's a CCD camera. So it is solid state, and I guess in a sense you could call it digital. So basically what it does is it has a grid inside. As the X-ray hits the grid, then it kind of charges the grid, and then it's able to develop the image based on the intensity of the X-ray hitting the grid inside of it. And these were really good. The image quality wasn't quite as good as a pickup tube, and but they didn't take as much heat, and they didn't take the time to warm up like the pickup tubes. So they were, I guess, you know, kind of off the shelf, ready to go imaging. And then here's your digital detector. So pretty much most of the stuff you're going to see these days, down here they use cesium iodide. So as the X-rays hit the surface of the cesium iodide, it turns into light. And then above that, then there's a photodiode matrix that then takes that light and converts it into an electronic signal, and then it's sent out the C-arm to the image processor, and then it's turned into basically real-time imaging. They can go up as high as 60 frames per second. Most of them you'll see run between like 15 to 30 frames per second, which is smoking fast in my book, that if you can get that much, you know, information across from the C-arm back to the video processor, the assessor, and then back to the screen, that's good in my book. Here's an unfortunate moment. So this is a broken digital detector. Kind of give you the inside. So what we call inside the detector housing, we call it the pizza box. And that's where it houses all the electronics for the image producing from the digital detector. This one suffered a unfortunate incident. It ran into something from down below, and it took the detector offline. It took out enough pixels that it was no longer of viable image quality. So yeah, it took a little bit to change this. These guys are heavy too. So even though it looks light and you're thinking, well, it's just, you know, the size of a pizza box, how much can it weigh? I don't know, they must make it out of like lead and bricks, because changing these guys can be a little bit of a challenge. So another system that they used, and conventionally pretty much from the beginning of fluoro up until, I don't know, maybe the end of last decade, sometime in the 2010s, the image intensifiers went away, and then pretty much everything turned to digital. Interesting enough, it uses a lot of the same idea, even though it's analog. So down here on this flat surface here underneath is made out of cesium iodide. And what cesium iodide does is it takes the X-rays and converts them to light. And so that makes it easier for the camera to record light over X-ray. And then what happens is then the image is then ran up through the intensifier, and then comes out the output. And here, right in here, is the CCD camera. Now this image intensifier is huge. It's probably like the biggest one I've ever worked on. It can do a full body scan if they're doing like a peripheral scan. And then for a CCD camera, this thing's huge. Like I said, if you imagine the little OR C-arms that have these, I mean, they're like this, where this is like, you know, the size of a small CRT TV or monitor. So this was pretty much the conventional way for them to make fluoro and cine images up until, like I said, early 2010s. And then the next step up from that was then your digital detectors. These all started coming out in the early 2000s, so they've been around for about 25 years. This one here is probably about 15-year-old technology. Still works the same as the newer ones, just didn't have the resolution and the speed that the new ones do. So as I mentioned earlier in the presentation, X-ray tube, X-ray production was basically identical for a traditional X-ray system versus a fluoro system. Now this particular guy is about the size of a truck transmission. It came out of a vascular system and weighs about 250 pounds. So that would make a really good X-ray tube to be hanging off your ceiling or moving on the overhead. But essentially, as far as X-ray goes, it works identical to a conventional X-ray system. Some things to point out on this. So right here's where your collimator will mount. And collimator will mount here. And then here's your cathode side of the tube. And I guess it doesn't want me to show the cathode. So cathode goes in there. Well, in place of the cathode high voltage going in there, they have what they call an in-grid, and we'll cover what that does. But like I said, other than it's a lot bigger than a traditional X-ray tube, it works identical to the ones that you'd have in like radiology. So here's the difference on what makes this a fluoro system versus a conventional system. So right here, this silver box here is called the in-grid. And so what the in-grid does is it screws into the cathode side of the X-ray tube, and then into the side of the in-grid, the high voltage from the generator for the cathode screws into that. So what this allows you to do is have pulsed fluoro. And so what the pulsed fluoro does is it synchronizes the X-ray to the camera or detector, depending on what system you have. What the advantage of that is that it cuts the jittery out. So if you're making the 30 frame per second exposure, this will only make X-ray every time you want to frame, and it synchronizes the X-ray with the camera. So some of the earlier systems kind of looked like they were like out of focus and jittery. Synchronized using pulsed fluoro then synchronizes the two together, and then you get a nice, smooth, clean image. So this is where I know the difference between conventional rad and fluoro comes in. Also with the collimator, you have your blades like I was explaining earlier, and you have your for your field of view, and then down here you have a big spiral collimator that increases and decreases with the dose. Now also on the bigger systems like in the cath lab and interventional radiology, they'll have filters, and they'll be like little copper fingers that will come out, and there's some settings for the dose on the radiologist or cardiologist can change, and we call them skinny man, regular man, and fat man. Well, what the filtration does is if you have a really big patient, then you can put in minimal filtration in there, and that will also cut the dose down and make for a better image. Or if you have some skinny little grandma that you put on there, you don't want to blast her with a big dose of radiation. It's not going to do anything for you. So that'll be like skinny man or thin man, and then you'll have your normal sized patients. So a little more action going on in the collimator than on traditional systems. So one of the first applications we'll cover is urology. What do they do in urology? Well, they remove cysts out of the bladder, kidneys, any kind of urinary blockages in the plumbing from your kidneys, and then the all too dreaded kidney stones. You really don't want to have to go to one of these rooms with a kidney stone. I guarantee you it will be rather awkward and painful. I've been in a number of those cases and seen what they do, and if you can go back to the old video game Asteroids, they basically take a laser and play asteroids inside your bladder and urinary tract. So enough said on that, but yeah, not a place you want to be. So here's a picture what you might see in cysto. They'll use a contrast. I'm guessing it's probably barium. It might be one of the contrasts. They'll fill the bladder up, and then it will show up on the X-ray image, and then that'll allow them to go in and clean out any blockages or cysts or kidney stones, depending on what they're going after. Some of the areas that you'll see that they'll use fluoroscopy and like surgery is like joint replacements. So like if they're replacing the I don't know, someone's knees, doing a total knee replacement, or a new hip, they'll want to test it and make sure that it works okay and it doesn't jam or have any obstructions before they send them out. Another area that they'll do is X-ray guided needle placement. So like if they're doing injections in the joints or other procedures, then the X-ray will help the surgeon or radiologist guide the needle to the exact spot that they need to go. And then also biopsies, so they can do like a needle biopsy, go to that part of the body, get a sample of the tissue they're looking for, and then be able to pull it out without having to open the patient out. And then here's an image you might see for a knee replacement. So they would take a lateral and a AP shot of the knee, and then they'll make sure that that's not me. Make sure the knee moves, its full range of movement, and that there's nothing obstructing or holding up the movement. Big place that you'll see fluoro used and cine used will be your vascular rooms, like your cath lab and IR. One of the areas that you'll see quite a bit in the cath lab is your angioplasty procedures. So if someone comes in complaining of chest pains, they'll do their diagnostic checks to see if there's any obstructions in the coronary arteries. And if there are, then they can go back and then do an interventional procedure and put in balloons or stents or whatever needs to happen to clear the coronary arteries. Next one's electrophysiology. That deals with the electrical side of the heart. So say you've got AFib, what they can do is then take out the AV node and then put in like a pacemaker to replace it so that your heart will beat at a normal arrhythmia. And then the fluoro and the cine then allows them to see where they need to place the device and then where to connect it to the heart. And then another one's devices, so those can be both like internal defibrillators as well as pacemakers. So here's what a typical image you would see in the cath lab. So you have your coronary arteries, and right here you have an obstruction. So what the cardiologists will do is identify it, see where it's at, and then they'll come in with a balloon catheter with a stent on it. Then they will deploy the stent, and then the stent will then grow inside the walls of the coronary artery and then keep them open so they're not causing the obstruction that was on the previous image. And that's from too many cheeseburgers, too many pizza, smoking, all those bad things that we do that we're told not to, and find out later that that wasn't a good thing. A little different setup. Now the machine itself is going to be exactly the same, but interventional radiology basically does the same stuff, but all over the rest of the body. So cath lab focuses just on the heart. IR focuses on anywhere else in the body. One of the things they do a lot of is they do a lot of biopsies. So they can go into it with the catheter and then go in and get a sample of tissue that they're wanting to see, and then they don't have to open the patient up like they would with traditional surgery. I'm going to say this is kind of not non-invasive, but like maybe minimally invasive procedures. I had a coworker that had liver cancer, and it was really devastating news. And they had just come out with this procedure a number of years ago that um, allowed them to take radioactive isotopes, and in a vascular room like this, then they were able to take the isotopes and implant them into the areas where the tumor was in the liver. When they were done with the isotopes, and they were able to go back and pull them out, and he's made a full recovery. He's been cancer-free for probably a good 8-9 years. So it's really cool that they didn't have to use like a linear accelerator and use radiation therapy, or do an invasive, like, biopsy or removal of the tissue. They were able to drop the isotopes in, kill the tumor, and be done. Another one that you'll see in IR that they'll do a lot of is central venous catheters, or PICC lines. You'll see a lot of that. So kind of like I said, different areas of the body that they'll be working in versus the cardiac, even though it's basically the same machine. Another specialty of using the vascular machines is neuro, and they'll go in, someone has a stroke, which is basically a narrowing of the arteries inside the brain. They'll do the same thing like they do in the cath lab. They'll put a catheter up there with a stent on it, deploy the stent, and then that'll open the blood flow back to that part of the brain. Another one is aneurysms. They'll be able to go in there and stop the aneurysm, and then hopefully with any luck, the patient will have a successful recovery from. Another part of that is implanting coils inside the brain. I'll be honest, I'm not exactly sure, other than the coils have electricity ran through them, and they do some kind of, I guess, narrowing or restricting of vessels. The next one, again, same type of machine, just depending on where it is and how you use it, is a vascular hybrid OR. What the advantage of a vascular hybrid OR is that it gives you the advantage of doing a minimally invasive procedure. And if things were to go south and you have to open them up like you would for an open heart case, you're already there. You don't have to move the patient. You don't have to do anything. You just bring in the perfusion machine and the right people, and you're off to the races. One of the procedures that they'll do in a hybrid OR is called a TAVR, and that's on transcatheter aortic valve replacement. So back in the day, if you needed valve replacement in your heart, they would have to open you up like an open heart surgery, and then put in the new valves and then close you back up, which was a horribly long recovery and invasive. With this, they can actually put the replacement valve through your femoral artery up your aorta, and then drop it into the heart and replace the old valve. So much easier and better than the old way. Another thing are devices. They can put, like, I've seen single chamber pacemakers that were about yay big, and I don't know, probably about the diameter of a ballpoint pen. They can run it up your femoral artery, and then attach to your inner chambers of your heart, depending on which one you needed the pacemaker for. And then another one is vascular grafts. And what they basically do is kind of like an open heart procedure. They'll harvest veins from like normally your lower leg, and then they'll do kind of a bypass like they do with open heart. So like one I saw was like a femoral artery graft, and they were able to take a big vein out of the patient's leg and then graft it into, I guess, bypass the old one that had kind of collapsed. And they didn't have to do any surgical or any invasive procedure. Patient did great and got their full blood flowing back in their leg again. The next step after that was, if they couldn't get that fixed, then the patient was going in for getting their leg removed. So it was a rather nice to see that kind of success. So here's a picture of a TAVR. So what they do is through the aorta and the femoral artery, they will then put the valve up into the body, and then here's your aortic valve that goes from your heart out to the rest of the body, and they just drop it in there. They sometimes have to do a little rotor rooting to get the old one out of there, and then they can drop the new one in, and it locks in there, and they're done. So really a big advancement over the old way. Another thing that you might see in hybrid OR, which are probably more common than really want to admit. So particularly men after the age of 50 and also smokers are susceptible to this. It's abdominal aortic aneurysm. Back in the day, if you got a AAA, you're pretty much done. It would be a rupture of your lower aorta, and all that blood would just go away. And like I said, the survival rate from that was with this procedure through other like through using ultrasound, they're actually quite successful now. So if you're able to detect it early, then it's just like another procedure like the TAVR or like a cardiac procedure. They're able to take through the femoral artery, run it up into your, generally about this area in your abdomen, deploy a stent, and then that reinforces the walls of the aorta where that aneurysm is trying to start. And if they're able to catch it in time, like almost 100% success rate. Unlike the stents, I don't know if you've ever seen a stent in like the cath lab, and they're tiny. You can barely see them. They look like a Chinese finger cuff. The ones that they use for the AAAs, they're about yay big around, and they're about the size of a quarter. So that'll give you an idea of how big that vessel is inside the body, and it gets even bigger closer you get to the heart. So they're huge. So that's a lot of blood that's going through those. So some of the areas that you might, if you don't work around the OR or vascular areas, is in radiology that they'll use the machines for. There'll be barium studies. You'll have your barium swallow, and then you'll have your barium enemas. And then they'll use them for spinal taps or other guided needle procedures. And then they'll use them for ERCP. So an ERCP is basically where they go through, you have to be intubated and under anesthesia. Then they'll go down through your abdomen and then go up to your common bile duct and say if you have gallstones or any other obstructions inside your common bile duct that goes from your pancreas, liver, and gallbladder, they're able to go up there and kind of go fish for the rocks or the blockage and pull them out. So with any luck, you don't have to get your gallbladder removed or have any additional surgery. And a lot of times they'll do ERCP in specialty rooms. Not every radiology is going to have those because you do have to be under anesthesia. So here's a barium swallow. What they'll do is they'll have the patient, they'll mix in the barium into like applesauce with crackers, with like juice, and then they'll have the patient swallow it. And as they're swallowing it, then they're able to track it going down through the esophagus. And if there's any obstructions or issues with them swallowing, then they can use therapy to help them swallow better. The risk to this is if they don't do this procedure, then the patient can have blockages, which then can promote pneumonia. So they'll have chronic pneumonia or other issues, physical issues with them being able to swallow and breathe. And thank you for your time. Any questions? No? Yeah, some fun stuff. If you haven't gotten into radiology, this for me is like kind of if you want to compare to old cars, you can compare this as like being a stick shift versus conventional radiology being an automatic. So if you can work on one of these and use one of these, then conventional radiology's, walk in the park, at least in my opinion. So kind of give you an idea of what, I guess using a car analogy versus X-ray. Okay, well, thank you. Appreciate it.